all the speakers up for the panel. You can stay with us if you like. And Francisco may be joining us. He's actually at another conference. And if he's able to, he will join us. So I'll just see if he's on screen. If we have questions for him.
Yeah. So please, if you have questions or comments, say your name, where you come from, and then ask your question, or did you come to the panel or one of the panelists? And if you don't, I see no hands. Yeah, please.
Perfect. So my name is Leanne, I'm from the UK. Firstly, thank you, amazing talks by everyone, and thank you to the chairs as well for that great session. So my question is two questions. One is, we see a link between diabetes and muscle mass. And I'm just wondering, in your opinion, why we've not addressed yet in the worldwide guidance for diabetes? Question. And then the second question is, when we think about preventative care for diabetes and the cost that could be associated with that, why does the average middle-aged person that was not know about the importance of maintaining muscle mass to help prevent their big decline in age? So I think maybe they're really good at that. But thank you.
Yeah, would you like to take it?
Okay. I don't think this is working. Okay. Thank you. So why is not I think these are the fundamental questions. So why is not included in the guideline? I think there's maybe two major reasons. One is probably still low awareness, maybe some of the, especially the diabetes guideline, but also the obesity guideline. They focus maybe on body weight, on blood glucose, and muscle is sometimes neglected, but it's a very important driver of clinical outcome. The other part, however, I think we have to admit that the evidence that is out there to build strong recommendations and strong conclusions is still somehow affected, for instance, by local consensus, which I try to explain in the final part of my presentation. And so that there are two issues. I think we have the responsibility to build maybe this evidence to try to make these topics more relevant in the guidelines. Why you don't have, or the average person doesn't have this awareness, I think this is the same reason, because it's not really exposed in the mainstream discussion. It's considered to be a secondary topic at best, but I think we are all in agreement that we should try to change that narrative too.
Would you like to add?
Just a quick point to elaborate on that. There's two kinds of evidence that guideline people are looking at. There's epidemiologic evidence and there's mechanistic evidence. In general, there's a resistance to formulate a guideline recommendation solely on the epidemiologic evidence, the associations. And there is a bias that probably good, but unfortunately it causes a lot of inertia where the guideline committees meet and they review the mechanistic evidence. And if there's paucity or insufficient mechanistic evidence, then there's a vote that we just don't have enough. And then they have to decide, do we have an expert opinion recommendation that's not evidence-based, or do we just punt? So you heard in, actually, it was in one of your slides from Aspen, because there wasn't enough evidence, they just were not recommend. We can't make a recommendation at this time. But I think your point is that people would still like to have a recommendation, even if there isn't enough evidence for the expert to at least provide guidance. That doesn't help you when there's a patient in front of you and you need to know what to do if the guideline says we can't offer a recommendation. That's probably not accepted.
Yeah, go ahead, Emery.
But I was wondering about, is that part of the population where in sleep pumps? Are there smart pumps with
So
And then equally,
that's a very good question. When we started back in 2018, so most of the farms that are included or the older ones that are not connected to a sensor. These last years, we've had maybe 6 or 7 people with the new smartphones included because we wanted this to be pragmatic, so we wanted to include everyone. But since it was randomized, we were lucky, everyone, like all the groups had equal efficient.
I'm glad we think that the neighbors event. I have a question for Rocco and Tim. Which are the methods for the measurement of master function to be proposing your algorithm? I know there are different methods and we cannot be able to capture what the group was.
I didn't put it in the slides, surprised me that was not there. But anyway, it's a good point. The overall goal of the algorithm is to aim for implementability, let's say, in practice. The two methods that are mentioned, the sort of recommended are Henry strength and C2 strength. And so hopefully these are implementable relatively easy in practice, including outpatient and primary care and so on.
Thank you for a very nice presentation. I have a question for Søren. Did you expect a rise in blood lipids, particularly LDL? So we didn't see that. What is the reason?
Yeah, that's true. Probably it has to do with the dose, I would expect, because if you use fresh coffee, for example, there is indications that LDL cholesterol would increase. But on the other hand, it seems the increase is kind of, it's very low, and the beneficial effects will probably overcome the deleterious effects of a very small increase. But we didn't see it in our study. Maybe next time I can present with higher doses, and then, yeah. Thanks for the question.
Can I ask, Afroditi? It's only occurred to me thinking about your lovely presentation, and I wasn't sure if looking hard at all, but I think it's quite kind of vague. And I wonder whether that's a methodological question, whether we should be powering this type of study on the perceived benefits or on the perceived problem. So if you power it on this particular hypoglycemia, you wouldn't need to do a much bigger study, but that might be much more important for clinical care.
Yes, I understand the question. I'm not sure we will have previous studies to base the entire on, but maybe we could look at the general distribution of severe hypo to do this. It will be extremely difficult to recruit so many people, I would guess. I just want to mention that these rates, as we saw, I compared with incident rates, like severe hypo per person year, seen in other studies or like in populations, populations, and these were much lower there. So I mean, a severe hypo can happen to a person with type 1 diabetes. It does happen. These rates are lower than what we see per person year. But it's a good point. I'm not sure practically how we would implement this.
This would be extrapolated outcome with everybody being managed for type 1 diabetes.
We will need more studies of this, of course.
I mean, we would, and I'm trying to determine if it's for a drug, and the causing severe hypoglycemia.
All the smaller trials that have not shown any severe hypos, we were the ones that have shown something now. But as I mentioned, the rates are quite small actually.
Give it the back.
Pretty, I think it's quite remarkable. I think anybody's attempted this study like that is someone diabetes. It's excellent. A question simply on the nature of the carbohydrate.
particularly in what you describe as the traditional diet. You did mention it briefly, but can you just tell us a little bit more, particularly how much dietary fiber, for example, that they have in that group?
These diets I want to mention, we took them from the dietary guidelines for diabetes that were in use back in the time. And this traditional diabetes diet recommends the whole grain and fiber rich. It doesn't recommend a specific amount of fibers. And when I looked at the fiber amount and the baseline, it was around 23 grams per day for that group. But the recommendation, because what we see here is the effect of dietary advice on low carb. We did not provide them with foods. We did not provide them this is it's not the effect of an actual diet. It's the effect of our advice, you could say. But this diet recommends whole grains, fiber-rich carbs, so not just sugars to increase the amount. But the fiber was quite, not very much, 23 grams.
I mean, I think that this is not a criticism of the study, but it is, I mean, our dietary recommendations, the DNSG dietary recommendations recommend much higher fiber intake that we achieve. It's hard to, it may be hard to achieve, but I think it's an important caveat for example.
I think because the fiber intake was maintained in the low carb group at the same level as before. And they didn't decrease their carb intake. So apparently they did make good choices for their carbs and a lot of vegetables to maintain the same kind of level, even though it's not the recommendation, up to the recommendation. But probably maybe some kind of supplementation could be argued in these cases.
Thank you. I'm going to have a look at the minutes. One more comment for Afroditi, and thank you. I would comment on the reduction of insulin doses that you said. That is quite effective considering that we are decreasing the carbohydrate. Maybe looking at the total dose and also on the buffer dose, maybe on long term, considering that lipids increases the rate for final good response, maybe.
Actually, yes, I think that was one of the main things I considered when I thought that the reductions were not that big as expected. And something I consider was the increase in fat and protein in this group, because we have seen in meal studies that insulin requirements increase in time on fat and protein. So this might have attenuated the expected reduction in insulin doses by carb reduction. So yes, thank you for this point. I think it's part of the mechanism.
So, any more questions from the audience? Otherwise, we'd like to ask we saw a different visual patch and EMR.
Yeah, a small decrease, yes.
Yeah, but could that be random because you do a lot? Oh, and if not, what is the mechanism do you think?
Yeah, the mechanism we don't know. So it's different. We saw the same in animal studies. That's why the bite is. But of course it can be. We did a lot of it.
Yeah. So, Andreas, the last.
Just a simple question. I remember somehow the capital is expected to use filter copy, is that right?
Sorry?
Filtering copy.
Yeah, then
the filter balance.
exactly. It does. But we see it as it can be a part of the explanation for some of the cohort studies that show this inverse effect anyway. And I think nowadays it depends a lot on where you live, whether you're doing mostly filter coffee or not. Yeah, but it's true. It is contained in the filter, most of it. Yeah, but yeah.
I think that's so should we
Close the session. Yeah. So thank you very much to our excellent faculty and our two oral abstract presenters, and thank you for your attention and great participation.